Welcome back. This is Daybreak, and thank you for staying with us. Dr. James Nyikal is the lawmaker representing Seme constituency with us in studio, a member of the Health Committee of the National Assembly. Peterson Wachira is the chairperson of the Kenya Union of Clinical Officers, and as well as Robert Pukosa, doctor, who is the chair of the Health Committee of the National Assembly, who as well is the Endebess lawmaker. And we are also joined from Sydney in Australia by Dr. Davji Atela, who is the Secretary General of the Kenya Medical Practitioners and Dentist Union. Your time is all appreciated, gentlemen. And Dr. James Nyikal, we are talking about consolidation of bills that the government touts as the key towards the drive of universal healthcare coverage. Given what's happening at the moment, what's further central is the personnel to drive this course, whether implemented or not, because we'll still have a healthcare system. I mean, have we sufficiently addressed some of the pleas that have been raised and grievances of medical professionals in the country, be it welfare or be it capacitating them when it comes to equipment, before even talking about some of the key proposals contained in the bills before the National Assembly and the Senate?
Let's even before we go to that, even the bills that you have talked about, everything is actually about implementation, not the nice plans that we do. The bills themselves will have to be implemented. And what are these bills about? They're about financing healthcare, looking for money. That is what you see, social health insurance fund, that is money. Primary health care fund, that is money. You look at emergency, that is money. Even what we don't have here, which is FIF, which we had before, that is also the money, how you get the money and spend it. So we are talking of just one aspect of healthcare. And even on those ones, we must start, even this one, shall we implement them effectively? Even within the bill, we have issues. In our committee, we have addressed them. When you talk of social health insurance bill that we have a big issue with when it is being implemented. The proposal in the bill is that we outsource claims. But claims is a whole thing about insurance. So that the committee has addressed and said that will not do. Transition, we may have it, but if we don't manage it, that what are we going to do with the staff? The bill was proposing they're all considered redundant and jobless. And we are saying, no, you can't do that. We must transition them, and then the authority, the new authority, will then use all the known processes of actually reducing your staff, picking those that you need, and seeing how you're deploying. Those are issues that will come in there. We had even enhanced funds, like for the teachers, these are there. So even within the bills, we still have issues. Like these enhanced funds. When they were within NHIF, they were paying huge premiums they were paying were not enough, and so they actually left. NHF left them. But when they went to the private sector, they are now paying bigger premiums. But this is money that was for employees, so the sums should not have changed just because they have left the place of introduction. Now, if you talk of primary health care, again, how are we going to apply this money? And even if you talk emergency, there's a lot of details that need to be done. But having said that, you are saying, even if we do this, what are the other issues? You have talked about one of human resource. Universal health care means this. You are unwell, you go to a facility, you can get the services you need without spending at the point, or if you spend, it's very little you can afford. That is it. Now, there are components of that. For that to work, you must have supplies. Drugs must be there. You must have personnel. That must be there. You must have infrastructure. That must be there. You must have equipment. That must be there. So when we come to that, you're talking of the human resource. That has to be sorted out by the governance structures. If it is national government, they're actually looking for only referral hospitals, about 3 of them. Now, the bulk of them are actually level 2, 3, 4, 5. Those are at the counties. You must have enough human resource. So we can do this, put this bill, put it in place, raise the money, but they must put this, the human resource. As of now, that's a big problem, and the health workers tell you. But not only that, KEMSA must be able to...
It's a whole different story. We'll talk about the crisis at the Kenya Medical Supplies Agency, because there was a report that was on September, that is within this month, of a crisis over the shortage of crucial drugs in hospitals, and this has affected 20 counties because of KEMSA's inability to supply drugs on time. Chairperson, Honorable Dr. James Nyikal points out the point of moving from, for example, NHIF, for many civil servants, that's including teachers and even policemen, to private insurers. I mean, what informed that policy, and why work, for example, why move from a functional system, say, to the proposals now that we have and are subject to parliamentary approval, for instance, as pointed out by Dr. James Nyikal, a member of your health committee?
Thank you. I think first I want to address the issue about, you asked about human resource and whether we have the capacity in terms of equipment and within the facilities to deliver to the primary, to the universal health care. You've seen what has happened is the government has done its studies and looked at how best can we be able to deliver this. And that's what has informed the issue of coming up with the 3 funds. When it comes to issues about at the lowest level of health, that is at level 1, that is how we've ended up recruiting 100,000 community health promoters. Once recruited, the government has provided them with gadgets. They have PP machines, they have glucometers, they have thermometers, they have many things which within that equipment that the president launched. Once these people now are equipped, because initially they were working without any equipment. 1, they have been equipped. 2, each of them has been allocated 100 households to take care of, so that he is able to visit those houses, find out what are the disease prevalence within that place, what are their problems, and within the gadgets which they have some mobile phones which they can be able to transmit, key in all your information about that family member, and be able to transmit it to the digital health agency, so that that information can be captured. That was not there before. Now, in addition to getting this 100,000, they were not being given anything. So now the national government is going to get a 50%, and the county government will get a 50%, so that they cost share.
What are they being paid then?
I think in Nairobi, they were being paid around 15,000.
So that is 30.
And then I think they are being paid around 15,000, something like that.
That's both the national government and...
That's both for national.
7,500.
Yes. In other places, they are being paid 3,500. In other places, they are being paid 2,500. It varies from county to county, depending on the county resource. And so what the national government has said, and that is what we allocate through the budget committee, is 50-50.
Okay.
Now, once we have them in place, the next thing is we are putting up the primary health care fund. This primary health care fund should be able to the government has, the Ministry of Health has done a survey of all the health facilities to see what is it that they require for them to deliver good health care to the public. Once that survey is complete now, the national government should be able to sit with the county governments and see how do we make sure that these facilities, the dispensary, the health center, the sub-county hospital, how do we make sure that this facility delivers the quality of care that is required? Once that is done, then that is going to be catered for through the primary health care fund to make sure that those facilities are able to deliver on their mandate. Then you now come to the other fund, which is for emergency, critical, and chronic illnesses. In the past, people have been exhausting. You find somebody maybe is a renal patient, somebody is a diabetic. You find that they exhaust their cover. Once they have exhausted their cover, some of those ones require maybe to enhance so that you can get better services.
All right.
But right now, with the provision of those covers, then it means that if you exhaust your social health insurance fund, you can still go to you are a diabetic, you are a renal patient, you are hypertensive, then you can still go to the critical emergency and chronic illnesses fund to be able to access those services.
All right.
Yeah.
Well stated. To my question now, Dr. Nyikala pointed out NHIF for
Yeah, I'm just coming to that.
Please,
yeah. Now, when it comes to the issue about NHIF, we are starting, and this is we are starting Social Health Insurance Fund, which is a new fund. NHIF has been default with many issues of corruption, many issues of fraud, and you remember this was being raised the other day. So what is going to happen is that NHIF will remain in place for the next 1 year, in as far as this bill is concerned. All the staff, nobody is going to be fired. Mm-hmm. Nobody is going to be dismissed. They'll remain in NHIF for the next 1 year. You've started a fund, which is a social health insurance fund. Mm-hmm. This social health insurance fund should recruit people from NHIF. It will recruit those who are competent to be able to, the number of staff that they require. Okay. It will recruit those who are qualified. And then those who are not, who would want to retire, let's say in a year's time, then they have an option of retiring and they get their package. Those who would want to continue working in the civil service, they'll be absorbed in the civil service at the same terms that they were working in NHIF, and their services be taken to where they require. So nobody is being, there's nobody who is being fired. Mm-hmm. What they are only doing is that you've started a fund, then this fund should recruit, the first priority should be given to the people who are in NHIF.
All right, and talking about NHIF, it wasn't a must for anyone to be a member of NHIF. But this bill, according to the proposal, it's going to be a mandatory registration for all Kenyans, including children, at birth.
Yes.
I mean, who will, for example, because the regulations will come as you have mentioned thereafter, who will then pay for the majority of Kenyans who are unemployed under this scheme which is proposed?
Under this scheme, majority of Kenyans who are unemployed will have, that you're talking about almost 80% who are working in the informal sector.
Correct.
Those who are able to pay, they should be able to pay. Mm-hmm. Then those who are not able to pay, the government should be able to provide a fund. The government should be able to provide not even a fund, I'll say a mechanism to which these people can be able to access money to pay into this NHIF, and then subsequently, these people, these people will be made to repay that money that you've been able to access. Then you have those who are extremely poor who cannot be able to pay, the ones we call indigents. Then for the indigents, the elderly, the vulnerable, then the government will be able to pay for them. They'll be listed, and then the government will be paying. And the biggest challenge that has been in the past, especially for indigents, you had indigents who are being paid for. We had Linda Mama program. We had Eduafia, who are in those programs. Okay. The biggest challenge that was coming from those programs was that the ministries were not remitting the money in time. So I think for this one to work, then the government must remit the money to the fund in time.
Okay.
And we've seen, I think we've seen this government, since it came into power, remitting the money for the counties in time. So to me, I'm not worried that they'll be able to remit money in time once we've appropriated.
Thank you.
And for the first time again, in this fund is going to, the money will be appropriated by Parliament for those who the government is going to pay for. And for all those other programs that are going to be supported, then Parliament is going to appropriate.
Thank you.
The fund, just a minute, 1 minute, the fund will also not just sit down and arbitrarily approve its own budget without reference to the National Assembly. The National Assembly will appropriate, and if there are any amendments to the budget, then they'll help to present a supplementary budget for approval in the National Assembly.
Thank you. Some follow-up questions, of course, but we'll follow up later. But let me bring in Dr. Davji. I'll come to you, Peterson Wachira. Are the reasons given by the chair of the Health Committee and Dr. James Nyikala, member of that committee, to you as the section of the Medical Practitioners and Dentists Union satisfactory from where you sit?
Thanks, Abdikadir. I think the narrative that is being given by the chair is quite a good narrative. But you see, the reality of this thing is quite different. And I think this one you can put into clear perspective if we look at the National Hospital Insurance Fund and the way it has always been used. If you look at it, 80% of that money used to go to mostly private hospitals. And the public hospitals have been dysfunctional amidst that period. Now there is a scenario where we're having now the Social Health Insurance Fund. What mechanisms have been put differently that will make sure that now these funds that are being collected actually beef up operations in the public facilities? The other thing that is coming out very clearly that I think has not been handled is that currently, as we speak, and as we have hope to have a universal health care or universal coverage, the primary health bill brings about something called the hub and spoke, whereby there will be mop-up of the community with these community health promoters, and then they'll be referred to the spoke, the first facilities, or the dispensaries of level 2. Those facilities, as we speak, are totally dysfunctional in the sense that you realize that probably each of them will be having like one nurse, or there will be no health professional in them. And then it talks about, after that, it will move them to level 4. The level 4 facility, as per the guideline of the Ministry of Health, need to have doctors, need to have nurses, need to have all the health professionals up to a particular level. But in this case, you realize that as we speak, most of the sub-county referral hospitals have one doctor, or if lucky, one pharmacist, if lucky, one dentist for almost the whole sub-county. So as the beautiful narration comes up of these, of the plan, as we speak, it is dysfunctional. Number two, as these things are also being said to be implemented, we must remember that health is a devolved function, as it has been said. What mechanisms are there to ensure that there will be employment of health workforce? If you look at the Kenya Kwanza manifesto, it said that on the baseline, the first thing which was put up in place was to have 20,000 health workers. Because then that will ensure that there was, the services are being delivered. There was an aspect that the national government and county government will see mechanisms of bringing an health service commission. That was to bring about the recruitment. So yes, the narration comes in and there is a promise to it, but will it be implemented?
All right.
I think I want to bring out very, very strongly on this social health insurance fund. To me, I feel like it's a fund, if not well keenly thought about, will actually enrich the private insurance companies. And why am I saying this? Because it's act to collect the funds, but then they'll be outsourcing of the service provision now by a different body. Which body will be this? Because ideally, if you look at even now the NHIF that is currently running, who has run NHIF down? It's the government. Why? Because the government has taken up funds from the government to private insurance. We have all the state officers operating in a private insurance. We have county employees, in fact, counties running to private insurance. We have teachers. We have police, both in the private insurance. So in a year, government actually spends over 150 billion to private insurances. Then now we are saying here we do not have enough funds in the National Hospital Insurance Fund.
Okay.
So it's a reality that we must look at. Why is the priority?
Thank you. Peterson Wachira, I'll come to you, of course, and Dr. James Nyikala, because there are fundamental issues that also need an address on. For example, the move of police officers and teachers to CIC, which is a private insurer, and even a bulk of the civil service who are insured by private insurers, yet we want to attain universal healthcare coverage. Peterson Wachira, I mean, is this entire debate and drive one that encompasses or embodies your call, and you have been passionate about this, the creation of a health service commission? You even presented this before the task force that was collecting views during the Building Bridges initiative, which ended up with the Constitution of Kenya Amendment Bill 2020, quashed by the courts. I mean, is there the appetite for the same from the current administration?
Thank you. And we have also presented before the bipartisan team on the same, and with the view that basically health should be in the national dialogue. But let me come back to the issue of health human resource. And let me say that it's concerning that we are having public participation in Lodwar for these bills. That is the first concern. The second concern is the speed at which these bills are being taken. And you know, we were concerned and we wondered why the Ministry of Health called us for public participation, which usually happens in Parliament before the bill was taken to Parliament. But now what is coming out, it's like that was being done to managers, and so that we will not appear before the National Assembly and the Senate on the same, yes, of which we will not be able to know if whatever we presented before the Ministry of Health was actually taken into account. But coming to the health human resource, we are really avoiding the conversation about the mainstream healthcare workers. Health promoters are not healthcare workers. They are health workers, but they are not healthcare workers. And for us to be able to implement and to see the fruits of universal health coverage, we must have the requisite numbers in the right mix in those facilities. Because what is going to happen is that we have brought in people to promote health. And we know what promotion is about. It's about sensitizing people about the diseases that are prevalent in their setting, how they know they have the disease, and what they do about it. And what they do about it is that they are going to come to those facilities. When these Kenyans are mopped up and flock into these facilities, okay, they are going to find an environment where you do not have these health human resources who are supposed to deliver the services that the promoters told you that you are going to get. So these people are going to get frustrated. We are not seeing anywhere where we have that deliberate plan. And you know, one thing I like about this government, and even the ministry, is the proactivity and the boldness to venture where others probably have failed. And we want to see the same with the health human resource. But where did we go wrong? Because, as Dr. said here, all these things, we have provided solutions. Okay. In 2013, and I'll keep saying this, when we were going into devolution, Kenya committed before the WHO, our CS Health, then Macharia, committed to the World Health Organization. And this was regarding the health human resource. One of the items for us to achieve the universal health coverage was the health promoters, the CHVs, and it's a good thing that now this government is getting that right. The second item was about the shortage of human resources. We committed as a country that annually we would recruit 12,000. That is signed before the WHO. Up to today, Abdikadir, if you ask the Ministry of Health, if you ask the county governments, how many health workers do you need per facility? They don't know. We have been doing this thing called WISIN, Workload Indicator Survey, to determine the staffing levels in facilities since 2018, when the staffing norms and standards elapsed. So up to now, and as we want to launch universal health coverage, we do not have a clear plan. We do not first know the numbers that we actually need to have in the facilities. And now that we are even expanding, they'll be going into the communities. Okay. And we do not have a deliberate plan to do that. Now, in the plan, it is documented. And it's a promise that was given when we met the president, when he was campaigning. We had a session as health workers in Catholic University. And there was a promise that within the first 100 days, we were going to have 20,000 healthcare workers, of which we actually said they were not enough, that we actually needed the 20,000, and then we needed annual recruitment so that we can be able to establish that staffing that will be able to support universal health coverage.
Was that achieved?
It wasn't, and what is concerning is that we do not see a plan, because what we need to see is we are seeing a plan on CHPs. We are seeing a plan on money, how we are going to probably get money to deliver several things. Okay. But we are not seeing a plan on how to ensure that we have the people who are delivering the services that we are promising Kenyans that they are going to get. Okay. And let me say that if we are not going to get it right, with the health human resource, I can assure you, we are not going to achieve the universal health coverage. And lastly, in the management, because the strikes that we have seen are from ineffective management of health human resources.
Okay.
In the same document that we committed, we had provided that we were going to put in place interagency coordinating committees, okay, both at the county level and the national government, and this speaks to what we have been asking for. Because when we're asking for a health service commission,
okay, thank you,
simply what we are saying is that we have noted that there has been ineffective management of health workers, okay, and we want a body that will be able to come now and effectively manage the same. If we had the interagency coordinating committees from the onset, yeah, at the county level and at the national government to ensure that the policies on management of human resources were actually implemented, we wouldn't actually even be asking for the health service commission.
Thank you. Dr. James Nyikale, I come to you. Of course, you have been taking notes, but the counties are a critical pillar in this whole setup that we are discussing here and the drive towards universal healthcare coverage. But we have seen just this week medical professionals who have issued notices of strike, Nyamira, Meru, and other counties. I mean, talk to me about this, because we already have crisis at hand of standoff between the professionals and the counties, yet this bill places emphasis and importance on the counties. I mean, how will that relations be bettered? Would it be worse? Would it be better? I mean, how will they coordinate in all this aspect of universal healthcare coverage?
You know, we're discussing two things. Realize that. We are discussing the bills. What are the bills doing? The bills is providing finances. The fact that you have money does not mean you will achieve what you wanted if the other things are not done. So basically, what Parliament is doing at this time is actually getting a bill which we hope, with all the amendments that we put in place, will now make money available so that the executive can implement. Now, where we are now is implementation at the executive. I told you, UHC is there. There's no mystery about it. People are making it look like there is some magical thing. When it drops, it's called UHC, suddenly, there's nothing like that. You must have all the aspects of all the components of health system working. You must have the staff. You must have the drugs. You must have the equipment. You must have the governance of that. That does not come from this bill. That comes from the executive. Now, the executive, in this case, will include both the national and the county governments. And that is where I'll say he's raising very important points. His point about the speed, I'll tell you, in our committee, we have even indicated, we are moving very fast. It is good, because this government is committed to getting things done fast. But sometimes it may be too fast. But let's give them the credit that they want to do that. And if the executive fails, Parliament will actually look at it. Even my chair, who is actually from the same party or the same coalition, yeah, okay, will actually now take the executive to task, because that is the work of the executive.
Okay, Dr. Nyikale, you will proceed, because you have mentioned a very important aspect. You talked about the set of our infrastructure in terms of the healthcare system. You talked about drugs and resources, for that matter. I mean, just this month, on the 17th of September, crisis of a shortage of crucial drugs in hospitals reported by the Kenya Medical Supplies Authority, Chem. At least 20 counties have reported lack of essential medicines. The infrastructure is still wanting. You look at its state, it needs a lot of refurbishment and need for new hospital centers and facilities. Did you have the listening ear, the executive, that can undertake all this?
Well, as Parliament will say what we need to say, then the executive will do it, and then we will oversight them. As it is now, I say myself, not the health committee now, I'm concerned that are we looking at the health human resource, the human resource for health effectively. He has said something. And there are many things in this country that actually are being taken for granted, but there are issues. That if there was an interagency that would discuss the issues of a human resource between the national and the county government, it would work. But I'll now tell you, In the Constitution, there is something called Intergovernmental Relations Technical Committee. It has subcommittees that are known as fora. This is where there should be a meeting between the national and the county governments and work out this. If that was working well, it should have. In my view, it isn't working well. That is why we have these problems.
Okay.
Then it's just the numbers. I'm also concerned, do we have the numbers in public facilities? The numbers of health workers trained in Kenya are there. If you take the nurses, they are there. If you take the doctors, they are there. But some are unemployed. So do we have enough? Now, this fund will not directly employ them, but it can if things are done well, because we are also working on something called FIF, Facility Improvement Fund.
Yeah.
What will this do? This will actually make sure that when the facilities are paid by this fund, then they have more funds. They can actually now take off some of the financial responsibilities of managing the hospitals and release the money for the government to employ more people. But these are things you should work out carefully and diligently. Then you will have to come supplies. Again, that's a matter of the executive. We have, as Parliament and as a committee, even looked at the issue of drug supplies. When we put those recommendations in place, it goes back to the executive. So the government actually is challenging itself more than even other people, because it's taking up tasks, putting up laws that are bringing as he said, good intentions. That must now be implemented. Human resource, very key. The other one is supplies, very key. Even for the primary healthcare, even the primary promoters that were actually launched yesterday. If you don't look at those two elements, it will still not work.
Dr. Pokose, two key, fundamentals here, and this is that fact number one, that we are below the recommended Abuja declaration in terms of our funding for the healthcare system, which was the threshold of 15%. We are at 9%. You look at the World Health Organization threshold of doctor-patient ratio, which is below the standards that the UN has set. And here we are talking about, for example, all these proposals that will end up universally covering all Kenyans in accessing quality medical care across the country. I mean, how then do you attain these two very important aspects, which one speaks ratio, of course, to employment of more professionals to cater for the patients and bridge that gap, and then two, more funding to the healthcare system generally through the budget process that I'm talking about, in order to achieve, for example, state-of-the-art facilities and also the capacity building of the medical professionals in terms of funding. I mean, how can we attain these two, even as we talk about these bills that are before the National Assembly and the Senate?
Thank you. I think I want to begin by first saying that with the current structure that the government is putting in place, where there is now equal emphasis on both preventive and curative services, I think that will drive us towards attaining of universal health care, because in the past, we've emphasized more on curative, and on the preventive side, we've not put a lot of efforts on it. In calculations that have been done, $1 when you spend it on prevention, it is able to save $9 for curative. And that is, I think, where the government is trying to go. Where we're talking of these primary health care promoters, their job is not just to identify who is sick. Whenever they are working there, their job is also to tell what are the health lifestyles, what are the preventive measures that can be put in place to make sure that people do not catch diseases. In the past, we used to get where we used to call them poroafia, where people would go to homes. Are you using your toilet? After using your toilet, are you washing your hands? And recently, COVID has taught us a lot because of washing our hands every now, often and then, using hand sanitizers. We've been able to prevent some of the common illnesses that we would have gotten. When it comes to achieving the Abuja declaration of 15% in terms of budget, and even the ratio of the nurses to patients, doctors to patients, I think it is resource dependent, because when you look at our healthcare system now, our healthcare system is in such a way that many of the health functions are in the counties, except maybe referral facilities, which are still national, specialized hospitals like Madare, spinal. Those are still under. Those are which are under national government.
Okay.
When you look at, there's been this misconception where people talk that the national government is giving a lot of money into the health sector, which should have been given to the counties. It is not true, because the money that is given to the health services at the national level, it goes to personnel emoluments, it goes to commodities in the referral facilities. We are talking of Kenyatta University, you are talking of Kenyatta National Hospital, you are talking of Moi Teaching and Referral, you are talking of even our research facilities, you are talking of KEMRI, you talk of KEMSA. That is money that is going to those facilities. And when it goes to KEMSA, it is supposed to provide commodities and the distribution to the counties and also the national facilities. So for us to be able to achieve that, it has to be a concerted effort between both the county and the national government. So that, one of the, and that is why this FIF bill is coming, because counties have not, when they've been able to get the money from money that is meant for hospitals, that money has not been ring-fenced in the past. Because you get money from the health facilities, then you have other priorities. You want to do the road, you want to do other things, that money goes there. You want to employ maybe what we call the law enforcement, that money goes there. So there's been no real serious concerted effort on how do we address the manpower in terms of the counties. And that's why the Secretary General of Clinical Officers Union says they have appeared before the dialogue committee to raise the issue about the health, because Health Service Commission, when teachers were talking of Teacher Service Commission, other commissions, I think our healthcare workers never bothered with that. Okay. But, and now they are, I think it's a good move that they are able to appear before the dialogue, so that their issue about health service, how do we manage the human resource within this sector of the healthcare. And I think it is true that the Kenya Kwanza team supports the issue about the Health Service Commission. But how do we do it? Okay. Yeah? Okay.
And of course, you are here in your capacity also as a politician representing the great people of Endebet's constituency. You talked about the achievement, for example, of the 15% Abuja declaration. To attain that, there are a lot of factors dependent. That includes budgetary constraints. I mean, as a politician then, don't you think if the government generally lessens on unnecessary expenditures, we can attain that? For example, just to give you an assessment here, that the National Dialogue Committee sitting at the Bomas of Kenya, chaired by Kalonzo Musyoka and Ishungwa, will be paid 50,000. That is the chairpersons per sitting as members, and the others will take home 40,000 in 60 days, which is the timeline within which they have to deliver the report. They will have gobbled up 106 million Kenya shillings. This, coupled with what the Deputy President Rigathi Gachagua said, was ministers changing clothes at airports, I mean, amid austerity measures, having the largest delegation during the COP27 climate conference in Sharm el-Sheikh in Egypt, excesses in terms of the fuel guzzlers that the government officers drive. I mean, and this is not just an issue with the current administration, but has been the same and a common denominator with other successive administration. If we can cut on these unnecessary expenditures as a state, can't we deliver on that basic things like healthcare, education, and infrastructure?
I think I agree with that. That it is when we cut on these unnecessary expenses, we should be able to support many of our programs. But I think it's looking at the whole working environment in which we are in. We should be able to look at, because you look at in other sectors, I want to give you an example. when you look at, you go to a sector where at the managerial level, you have many managers managing even less workers. Mm-hmm. For example, I can give you an example. If you go to Parliament, because that's where I am, when you go to Parliament, go to a department of catering. In the department of catering, you have more supervisors than the people who are working. And the supervisors are to give instructions to the people who are working.
And earn more.
And earn more. And the people who are working, those are the ones now being supervised by these ones, telling, do this, do this. Okay. And instead of these ones now, who are supervisors, also engaging in those. Now you ask yourself, do you really need this number of supervisors? Because it seems in the way our structure of working is, I think there's something wrong with that.
Thank you.
That we should be able to look at it.
Okay, thank you. Yes, Dr. Budgetary.
Yes, I just wanted to bring up the part that Dr. Pukusi had put up earlier, that one which I think I've had it quite a lot of time, and it's like now a chorus from the minister, from the president, that 1 shilling injection into the preventive healthcare is a saving of 9 shillings in the curative. It's very correct. But there's also the aspect of $1 injection in the health workforce is a $9 injections in the economy. It means that if we have this FIF bill that we're talking about now, and we want actually to collect these funds to help running of the hospitals, the first thing we must focus on is that, are these hospitals able to work? How much are we going to have in the economy? If we have a level 4 hospital with doctors, nurses, clinical officers, and all the health workforce, it means that these hospitals will be actually generating in the economy. And this is one thing that I will say the government has really, in a strong way, ignored as something that is very important. The other thing I want to bring forth is that, you know, Abdikadir, this issue of public participation on most of these bills or these discussions, in fact, including our petitions in the bipartisan team and even with the one we did with BBI, I would say they're always an intelligence exercise. Why am I saying this? Because most of the times the things that are to be done have already been decided. So the essence of public participation that is already being done is always just, I would say, a cosmetic process. So therefore, these things that be decided, it's very important that what is taking place needs to be something that is robust and is actually able to make things work. As we speak today, the doctors in Nakuru who are on strike, the healthcare in Nakuru is not functional now. As we speak today, in Nyamira, healthcare is totally not functional because doctors are on strike. Embu County and Meru County have also issued a strike notice. Why have those doctors issued a notice? Because they're in the hospitals where there are no drugs completely. There are no reagents. In fact, the hospitals are dysfunctional. Doctors are there, the few who are there who have not gone to leave. They can't be able to, they can't actually help patients when necessary. Why? Because they're not supported. When they demand for more to be employed, they can be employed. So as we look at all these scenarios, and in almost 90% of scenarios, the county government would always say that they don't have a budget to promote the healthcare workers, to employ the healthcare workers, to buy the drugs. So when we talk about these universal healthcare, when we talk about how the paradigm shift, what really are people that are experiencing now as they await that? Why can't we start by actually making sure that things are working in the baseline? Because the politics, and this was a clear reality, the politics of Ministry of Health and the politics of the Council of Governors and of Counties will not make anything move. Those bills will come and they remain just documents and policies.
Okay. Yes, Dr. Nyikal. And this generally is, again, on some of the members that the entire scheme seeks to net. And, for example, what's the fate of retirees in terms of being members of this new scheme?
Yeah, they'll pay. I mean, once they retire, some will retire with their schemes that they have. Now, if they have those schemes, they will probably use. That's why, you know, you say there was a fear that these enhanced schemes should actually leave. There's been an effort in this bill actually to bring them back and reorganize how they are done so that they don't lose money. That can take care of those. But if people, if they can also pay as voluntary paying, because everybody must pay. But if there are some retirees who are actually indigents, then of course they'll be covered as an indigent. So theoretically, everybody should be covered as proposed.
Okay.
What I keep saying, as will be implemented, it's another matter. So everybody will be covered.
Okay.
But as we said,
yes,
nothing. I'm repeating myself, but I'll do it for the third time. Universal health cover. Everything is working. So when a person comes in, he's either not paying directly, or if he's paying what we can afford, or he's paying through social health insurance. But the structure must work. Primary health care, what does it do? It reduces costs. You see, now we are calling them promoters. Fine, they have had a name of volunteers, they have had a name of community health workers, now they are called promoters. It's the same. I know the first document. I actually signed it. But what it does is that actually it addresses the social determinants of health, which means at the community level. Then when you treat things at the very instant, let's say malaria is the most common thing. If you went to Western Kenya, people who have malaria, 90% of people who have fever will have malaria. So if these people can recognize and give a safe treatment, caution must be put on what drugs, my colleague said, they are given. But if they have simple things, blood pressure, if somebody can just measure, because blood pressure is painless, you don't know until some catastrophic thing happens, that just by measuring you, suddenly they realize, you know your blood pressure is high, you start treatment, you avoid stroke. Because if you went stroke, you are going to ICU, the expenditure on you. So if primary health care works, then it now saves you money. FIF, we had it in 2005.
Okay.
Now, what it does, very important.
Okay.
Right now, even when we have had Linda Mama, even when we have Edu Afia, even when this scheme, the NHF was paying, even if social health is paying, the money that will be generated by the hospital before at old levels were actually going to the county revenue. They were not playing back. Now with FAIF, that money will be there. So it will support those systems. But what we must do is what we plan, we must do.
Thank you. Dr. Pukosa, I'll come to you, and Peterson Washira, I'm sure you want to contribute to that. But first, you have a point? Yes, please, and then I'll come to you, Dr. Pukosa.
I really wanted to raise 2 points, because I really need the lawmakers here, and who are also medics, to probably contribute. One of them is privatization of health. We are seeing now, we are going into what they are calling primary care networks, where now you'll be using your card not to a specific facility, but to an ecosystem of facilities, and you can go to any facility, whether private, mission, or government. What we are going to see is that because we don't have enough capacity in our public facilities, of course many Kenyans are going to go to the private facilities, money will be paid to private facilities, and progressively, the government will see no need in investing in the primary health facility, because that need is being catered by somewhere else. That is one. The consequence of that, I'm worried about the next pandemic, because private facilities will never manage a pandemic. It is the work of government through the public health facilities, because the cost cannot be catered by the private health facilities. How are we going to cater for that in the view of our policies are going to privatize health and probably favor the private health facilities other than the public? I think those 2 points. And the last one, when we are saying that if you don't have a social health insurance card, you cannot access any government facility, are we going back to the colonial times? And what does that mean? Are we opening a leeway for corruption that if you don't have that card then and you're going to a chief's office, probably you might have to give something so that you can be able to get that service? I think that goes against the Bill of Rights, and that should be amended, not actually amended, that should be deleted.
Okay, expunged is what you're calling for from the bill.
Yes.
Dr. Pukose, before we take the feedback, allow me to take your points here, because he mentioned the question about privatization and also the aspect of the access of government services if you are not a member of the Social Health Insurance Fund. That coupled with this question, the Facilities Improvement Finance Bill seeks to, give hospitals to use money at source, that's the money that they fetch. Doesn't this raise the question or the concern about corruption over possible misuse or mismanagement of those funds at the healthcare facility?
Thank you. First, let me address this issue that has been raised by Wachira about primary care networks where we're doing classification in terms of facilities. Actually, what it does is that whether faith-based, private or government facility, when we do classifications, we want to understand at what level of care that facility can be. So that if I go to a private facility, I know that this private facility can offer this level of care. And therefore, even the government facility should be able to offer the same level of care, so that you have many options. It doesn't limit you. It doesn't mean that the private facility will offer better service than government facility. I'll give you, for example, if you went to Kenyatta University Teaching and Referral Hospital now, which is at Kenyatta University, it's one of the best facilities in this country that you can talk about. And any service that you think you can be able to access, whether you need a presidential suite or you need anything, you'll be able to get those services. The same doctors who are working in Kenyatta National Hospital are the same doctors who are working in Nairobi Hospital. And it's just a question of good management. If you went to Moi Teaching and Referral now in Eldoret, it's the best facility in terms of care within Eldoret. So the issue is management, making sure that the services are available and you're able to do that. Coming back to the FIF, when it comes to it doesn't mean that you are spending money at source. How FIF operates is that you collect the money, you bank, 100% banking. Once you've banked that money, for you to spend that money, you go to the chief officer or the CEC Health in the county. They give you an AIE, what we call Authority to Incur Expenditure. Within the hospital, each department knows how much they have collected. And they can now do their proposals based on what they have collected. Do your proposals, then that proposals forms your request to the county. Then the county now sits down, the county health management sits down, approves your budget proposals. Once they have approved your budget proposals, they give you an AIE equivalent to the bank statement of what you've banked. So it is not expenditure at source, and therefore it's actually a very transparent way. It is a way that it is going to even improve in terms of morale, because whatever we are generating, so you'll be motivated to, even as a department, to generate more, make sure that you bank all your money, so that when you now go to request for an AIE, you have a good amount of money. And this is a system that it used to happen in the past.
Let me just strengthen that for you.
Yes.
Before devolution, that system was working. Under the fear you are saying that there will be misuse and corruption. We actually, at district level, we are to employ what we call the district health accountant. So this guy was going around helping the health centers and the dispensaries with record keeping and audit systems. So it is workable. The counties can do the same. It's been done before.
Unlike the system now, where all the money is collected, put in the consolidated county account, then it goes to the national treasury.
Thank you.
And when you will request, that money is not pumped back to health.
Thank you.
It goes to other use.
Okay, let's now sample the feedback of the Kenyan people and the viewers watching this broadcast. And this was in relation to the road towards universal healthcare coverage in the country. 4 bills before Parliament. Here's what you're saying on X. The hashtag is Daybreak. The SMS code is 22422 at Citizen TV Kenya. This is from Engineer Lazaro, who says Kenya is being known worldwide by their unimplementable robust plans. New health care proposals are among big plans that will never see the light of the day. Problems come only in implementation. Wale Shonko says, whatever proposal that will be made for the healthcare sector, I don't think there will be any fruit since our biggest challenge has been implementation. Bob Otieno Wino says, in Kenya, on paper, everything is possible, but implementation is the biggest elephant in the house. And Ibrahim Bakari says, for universal healthcare coverage to succeed, all stakeholders, especially the community health practitioners, must be appropriately remunerated. A corrupt link in the system must be cut at the nerve for services to flow well. Godi Barasawere says universal health coverage is a great initiative, especially for the common man who needs proper healthcare attention. The problem is that the funds set aside for this program don't fully go to it. Cartels must be obliterated here. Daybreak, thank you. And Mogira_Jasper says, to add insult to injury, Ruto is taking over basic health, a function that is clearly for the counties or the county ones. Instead of fiscal prudence, we are creating doubts and double bureaucracies rather all over the place. All the more reason to reject this latest Ruto. Incomplete. Successful health reform must not just just make health insurance affordable. Affordable health insurance has to make healthcare affordable to everyone, regardless of their income. The hashtag is Daybreak. Thank you. And this is from Remy Butia. He says UHC requires strong people-centered primary healthcare, good healthcare system rooted in communities, skilled healthcare workers providing people-centered care, and policymakers committed to investing in universal health coverage. Thank you for your feedback. That's all appreciated. Before I say thank you to my able panelists here. At least 100 people have died and 150 others injured after fire.